Have you ever wondered what's in our blood? What it can tell about our well-being? What about the innovative technology used to unravel the mystery of what's in our blood? Hello, I'm Dean Whiting, and this is It's in Our Blood, the podcast series that explores the critical role technology plays in the pathology laboratory, in hospitals, and in the community setting. And here we have part 2 of our special podcast series, which takes the highlights from our recent Pathology Technology Disruptors Past and Future panel discussion. Enjoy. So that's sort of the grounding, okay? So that tells us how we've got to where we are today. Will it get us to where we need to be in the future? Let's have a look at some of the drivers of demand for healthcare in the future. So the Australian Bureau of Statistics looks at this on a regular basis, and this is from the 2016 report. And we can see that over the past 20 years, the number of 85-year-olds has doubled from 1% to 2%. In the next 30 years, the number of 85-year-olds will quadruple, will 4 times again. 55% of the population is older than 55, and this is really important because 55 years and older consume 53% or more of the healthcare services in Australia. Coleman, I have a question. What are some of the challenges you see resulting from the demographic trends? And, what will this mean from your perspective? Can you make a prediction of what this means for healthcare and particularly pathology?
Well, I don't think I need to. I think everyone is aware of the implications of this. I don't think I need to educate anyone that what this means. But from I guess a government perspective, it's sort of the perfect storm, isn't it? You have people living longer with better medical technologies and more technologies available, and you have less taxpayers to pay for it in a relative sense. So I guess that means that we need to do more with less. So it comes back to that efficiency point before. When you have a whole lot more people that you need to pay for because we have a universal healthcare system and that's not going to go anywhere, then you need to be able to fund those people with the appropriate healthcare that they deserve. So I think that's the challenge moving forward, and I guess related to this forum is how do you in that kind of challenge harness the benefit of technologies, this sort of coming wave of technologies, whether it be digiputics and all these fancy things that are coming. How do you use that and harness that to deliver better efficiency, and also take care of the relatively high proportion of older Australians?
Thank you. The second driver, I think, of increasing the demand will be the increasing burden of chronic illness. And according to the Australian Institute of Health and Welfare's Australia Health 2018 report, 50% of the population suffer from one or more chronic illness, and 23% have 2. And cancer, clearly, heart disease, mental health, diabetes lead the pack. Arthritis, chronic obstructive airways disease, and asthma are responsible for the bulk of the rest. So these become a very big driver of healthcare demand going forward. Now, I know, Mukesh, you mentioned that a moment ago. So as a GP, I'm sure this statistic doesn't surprise you. Is this consistent with the population of chronic disease sufferers that you're seeing in general practice? And what's your prediction for the future here?
As I mentioned earlier, I believe that the issues surrounding chronic disease management is the big picture in town. Internationally, they call it the part of the social determinants, and part of the international agenda is about dealing with this area. It was the disease of affluence in affluent nations, but actually it's also there in developing nations too. In Australia, it's of course across the whole population. I was at the Press Club in Canberra last year talking about this with the Victoria University, Mitchell Institute. There is a gradation across suburbs, even within Australia, within local government areas, of the people with markers for chronic disease and not meeting targets to prevent them. And that's a growing burden across age groups and across demographics, age, gender, ethnic diversity, all those things all add to that increasing burden of disease. And what we are doing in our practice and certainly in our area is putting a lot of investment into looking after these people. The current system, when it was developed, was working well for those who didn't have chronic disease, and we are developing, including in this city today, some conversations happening around how this can work into the future. And there's more of that happening next week as well. So these are all part of active, live wire discussions about how we can make sure people enter retirement well and healthy, because I say to my people who are my age that we've got 40 to 50 years to go, hopefully, and we need to be developing those 40 or 50 years in better health so that we don't have that cost issue and the fiscal cliff that is seen, especially in state governments, around the cost for health requirements across the population. I think we're in a very good place. We have great systems, we have great people, we have great technology. It's being allowed to use it in a system that is allowing that and enabling that to work better. And in terms of technology and pathology, access to things that you can make a material difference at the time of seeing the patient, because that will change them, because you otherwise lose the opportunity of looking after someone if you suggest they have a test and they don't go and get the test, or they do go and get the test and it's delayed and then they don't go back from the results. So all those points of continuing that care are lost. And so it's about joining up the care around chronic disease management into the future that will make this thing work better. But absolutely, it's across the population in our nation and internationally.
Yeah. It could be pretty scary stuff, really. Lucky we live in a place where we have such a great healthcare system. Frank, let me ask you the same question from a public hospital perspective. How's that impacting, how's increasing chronicity affecting, the demand for your services?
Well, I'll obviously from the data and the ageing data you showed, Dean, there's a tremendous increase. But I'm going to, as a director of a pathology service and a researcher, turn your question around a little bit. The question I always ask myself is, will the test make a difference? And in practice, I've always argued that you should always offer a test that's going to change the treatment. And many of the tests on the current Medicare schedule have never been evaluated for their effectiveness of outcome. And a lot of discussion from you about inputs, but not much about outputs. So I think the pathology model in this, certainly it's got to support prevention. There's no doubt about that. It's better to not have the problem rather than try and fix it. But we may be trying to shut the gate after the horse has bolted. So the question is, the diseases of ageing, for how many of those diseases does pathology testing really make a difference? So I'm going to be a bit radical here. The answer is it's not known. So I just wouldn't assume that doing more of the same is the right thing to do.
Oh, I agree. Yeah. No, it's a good challenge, and one which we'll address in part 3 of the discussion is exactly that point. And maybe we are measuring not quite the right things here. So according to the CIE report commissioned by Pathology Australia, Pathology Awareness Australia and PTA, Medicare spend is expected to increase 25% between 2015 and 2028, up to about $1,000 per person. But I wonder, does this keep pace with the demands? Does this keep pace with inflation? Does this take into account the increasing chronicity burden in the Australian healthcare scene? And maybe, of course, this Medicare spend doesn't represent the entire spend. It's maybe about half of the spend, because we don't know how much the states spend on healthcare. It could be as much again, maybe more, maybe a little bit less. But the question I have is, do our current policies for product assessment, technical assessment, for funding and for regulation, allow us to take into account the full end-to-end patient outcomes, the full economic outcomes and the societal benefits from changes in pathology technologies. So I'm going to ask Coleman first, and then we'll turn to Megan. But Coleman, how does a healthcare economist go about evaluating the benefits of a test for, say, MSAC application, and what factors, such as the predictive, the prognostic, the other benefits that we talk about here, such as societal benefits, how much do they come into account if you're mounting an application, an MSAC application?
So I think as, Megan alluded to, there are set kind of evidence hurdles that need to be cleared in relation to new diagnostics. Obviously the analytical validity, clinical utility are the three key hurdles there, and often we don't have the perfect randomised controlled trial that we would like to see. So we have to often piece all that evidence together, which is particularly challenging. And then at the last hurdle, the clinical utility, I agree that information is often not lacking, is often not there. So that means that the MSAC is looking at this going, well, am I just going to implement another test without it actually changing anything along the way, to Frank's point. So I think that if I had to sum up the three key hurdles, that would be it. But then there's obviously the economics. Once you've cleared that clinical hurdle, you need to make an assessment of the efficiency of what you're implementing, and efficiency, how it's evaluated at a federal level, is certainly about cost per patient outcome. And the patient outcomes we look at are quality adjusted life years, so every life year you gain adjusted for the quality of life. You need to make an assessment of that. But to your point, Dean, the parameters that are set around that evaluation of what is a quality adjusted life year and what kind of cost considerations go into that are quite narrow, in the sense that they're mostly restricted to the healthcare budget. I think whether or not that will remain the same into the future is an open question. I think there has started to be some recognition that we need to start evaluating what's more important for society, and things like returning to work and productivity are fundamental components. And in fact, the Reserve Bank governor made a speech the other week making this exact point in healthcare. We need to think about these efficiency gains that we're achieving from and measure them properly from new technologies or whatever it might be in the healthcare system. I think, just to finish off though, what we see at a federal level in terms of MSAC is quite unique. I think the guidelines that are in place, the process that you go through is quite transparent in some ways, and there's nice public documents published after those assessments. So we should be quite proud of that process that we have, because it certainly is not the case in other countries. But when you sort of filter down to more local levels and states and things like that, it's a completely different conversation. There's not that kind of clear, repeatable process going on. So it's a bit more of a free for all in terms of funding. So yeah, so I think moving forward we've got some real challenges in this space.
Yeah, and so in part 3 maybe we'll turn to some of those. Megan, I'm sure you have a comment here as well. Is it possible to include, or what is included currently in the calculations, and what other things would you like to be able to include in the future?
So I think Coleman's captured it quite well. So in terms of looking at the health outcomes, there's kind of quantifiable factors which are around directly clinical benefits for patients and downsides associated with the new technology. But that also encompasses benefits to the health system, so it can be around better use of health resources. And then we have really more qualitative factors, which is really where the appraisal of the evidence comes in. You know, we have a group of clinicians and consumers and health economists sitting around the table who bring to bear other factors in terms of their decision making around what should go forward or not. And those things are often around issues around health equity, the acceptability of the technology or the therapy or the test to patients, the burden of disease for this particular condition, what else is in the space around diagnostics and therapeutics for that particular condition. So, you know, those things are where the judgment comes in from the committee. And I can use an example because this morning I was actually at an MSAC, one of its subcommittee meetings, and they were talking about fecal calprotectin testing, actually, which will go through to MSAC later on in the year. So, you know, as a general practitioner who presented the evidence, so he brought that perspective, presenting the evidence. And of course it's a test where really the benefit is more around use of health resources rather than a direct benefit to the patient in terms of diagnostics. It's really a triage test. So the conversations about reduced colonoscopies, reduced specialist referrals and the like. And then we had a consumer perspective around the acceptability of the test, you know, and we'd had input through that consumer member from the Crohn's and Colitis Foundation, you know, the consumer end of people with inflammatory bowel disease, around the acceptability of the testing being a faecal sample test. So, I just use that as a, and then all of that advice will go through to MSAC itself, which again will bring to bear its own, members will bring their own experience and consider those questions as part of their evaluation.
Do you see in the future any need to change or expand or sub some topics in and some topics out to help in the evaluation?
So Colin made the point that generally the perspective is from the healthcare system. It's not a societal perspective in the sense of taking account of direct economic impacts. In the sense of the overall economy. Of course, if you broaden the perspective, it leads to much more data that has to be brought in and brings about more complexity and uncertainty, actually.
Yeah.
So, I don't know that there's any plan to do that at this point. But we certainly take a perspective that is beyond the MBS, all right? We look at, because the advice of MSAC flows through to public hospital practice and beyond the MBS, and increasingly, in fact, we're looking to have national approaches to health technology assessment and MSAC providing advice beyond the services that are funded through the MBS.
Very good, thank you.
Thank you for listening to this edition of It's in Our Blood. Look out for further topics in this series or go to pathologytechnology.org.au. This podcast is produced by London Agency, Melbourne, Australia.